Hello and welcome to a very special episode of the Digital Health Hubcast. I'm Hannah Clemens and I'm co-hosting this episode with Dr. Marjorie da Costa Abreu. Welcome, Marjorie.
Hello, Hannah. I'm super delighted to be here today.
It's great to have you.
Thank
It's nice
you.
to have a partner in crime.
Always.
We're here today at the Insigneo Showcase at the University of Sheffield, an all-day event that's highlighting some of the most exciting research that's happening right here in Sheffield. The Insigneo Institute brings together researchers with expertise in biomedical imaging, healthcare data, computational modelling, and digital healthcare technologies to deliver cutting-edge innovation and translation of technologies to solve major health challenges.
Definitely, Hannah. We are very excited to hear from some of those speakers working in the digital health space here today. We will speak with Dr. Dawn Walker, who uses electrical impedance spectroscopy to support early diagnosis of cancer. That's a mouthful, isn't it?
We'll speak to Dr. Buckley about how wearable sensors can advance better diagnosis and care of people with neurological diseases.
Last but not least, we will speak to Professor Purshouse, who has developed a computational model to understand what actions policymakers can take to reduce the health gap between deprived and affluent communities in Scotland.
It all sounds great. I'm ready to go. Are you?
Amazing. Let's go.
Welcome, Dawn Walker, to the Digital Health Hubcast. It's great to have you here today at the Insigneo Showcase.
Thank you very much for having me.
Tell us a bit more about yourself, Dawn.
I'm an academic in the School of Computer Science in the University of Sheffield, and I'm also a member of Insigneo. My original background was in physics and medical physics, so I became interested in a technique which can be used based on passing a very small current through tissues in order to diagnose early cancerous changes. So I did that for cervix in my PhD. I've worked very much more computationally in the last few years, and now I've gone back to look at applying this technique to oral tissues.
Pretty awesome. Can you summarize? So you just gave a talk in the showcase. So could you summarize the main points of your presentation?
Yeah, sure. So I'm working with a very multidisciplinary team at Sheffield. So we are using the same technique which has been used in cervical tissues to try and diagnose early oral cancer, which is a growing problem in the UK and in Yorkshire and the Humber in particular. So the difference between the two tissue types is that in cervix you get one type of tissue with quite well understood changes. In the oral cavity you have lots of different tissue types with lots of more complicated changes with different layers on the top of the tissue called keratin, which can cause additional problems if you're trying to develop techniques like this. So we're very, very lucky to get funding from Yorkshire Cancer Research, who are a Yorkshire-based charity, to support our multidisciplinary work in this area. So I'd really like to thank them as well.
So it sounds like it's a lot more complicated in oral cancer then. So how does that manifest, those complications? What makes it so challenging?
Well, different characteristics of the tissue affect the electrical properties that you measure in different ways. So whereas in the cervix we understand these very well, in the mouth it's a much more complicated situation. So we need to understand more about how the changes that you see with progression of early cancer in the mouth, how those changes directly impact on the electrical properties that you measure. What we can then do is include those in a computer algorithm, which we're hoping to develop to identify the different tissue types.
You mentioned in your talk, Dawn, that you kind of start a lot of this work in the lab, you're sort of building in vitro models. I wonder if you can tell us a bit more about how you take that information and then put that into your computational models.
Yeah, sure. So what we're doing is growing what's called tissue-engineered models of normal oral tissues and precancerous oral tissues in the lab. We're collecting electrical measurements from those with an existing handheld device. And we are also taking images of those tissues so we can actually see the cell structures in those tissues. We can then build virtual oral tissues, or VOTs, which are basically simulations of those tissues in order to be able to predict the electrical properties that we'll see from them.
Wow. It sounds like there's a lot involved then. How long does this take from kind of day one, starting in the lab, to getting those models?
Well, actually, to grow the models themselves is round about 18 days. We found that the best amount of time to get good tissue structures and good electrical readings from them. Taking the electrical readings themselves is extremely quick. It takes a few seconds. So that's one of the reasons why we want to try and develop this methodology to be used in the clinic eventually. Building the simulations, again, is quite time consuming. So once we have the basic simulations built, we can adapt those models to run lots of different tissue structures. Solving them takes a few minutes to a few hours, and we are then using the machine learning approach to try and categorize those readings, and again that's something that can take minutes to hours. So all in all, it will probably take a few weeks to go from growing the tissue to getting the readings.
Wow, that's really astounding that it's so quick. Once you get into the computer models, it's just minutes.
Yes. So the idea is that once we build the computer models, we can very quickly simulate the tissues. We're using those to get an understanding of what the different tissues look like and how they affect the electrical measurements. And the machine learning models themselves, once they're developed, the idea is that they could eventually be deployed in the clinic and give the clinician an indication of whether that tissue is normal or potentially cancerous in a matter of seconds, which is much, much faster than the days that a patient would currently be waiting for a biopsy result.
Yeah. So tell us a bit more then about the positive societal impact that this work will have.
Well, there are a few things. So, as I mentioned, oral cancer is a growing problem. The prevalence has increased around 60% in the last decade alone. So more and more patients are getting referred by their GPs or potentially their dentists to oral health specialty clinics in the hospital. So that causes a big impact on the NHS. At the moment, it takes time for those patients to be seen. If a biopsy is taken, it takes several days, which it has lab costs associated with it. It causes stress for the patient while they're waiting for the result. And also, we cannot take repeat biopsies at the same site, which means it's difficult to properly monitor the disease over time. So if this technique works, what it means is that a clinician will be able to place the probe on the tissue, get a result within seconds, and then know whether that patient should then be biopsied or whether to adopt a wait-and-see approach, where the patient could come back in a few weeks or a few months' time for another reading, which will take a lot of stress off the NHS and also the pathology services involved in diagnosing the biopsies at the moment.
Wow, incredible. And a lot of stress from the patient as well.
Oh, absolutely, yes. So hopefully the idea is those patients with suspicious lesions that are progressing can be identified, diagnosed and treated much sooner, which will ultimately lead to better patient outcomes.
As a follow-up question, based on what you are doing now, which is computational, I wondered if you could talk about a bit more about if you had any interaction with the patients to see their view on, sharing their data, having their data being processed by a machine learning model, which is, for some people at the moment are quite scary. Do you have anything on that sense?
At the moment we don't, because we've been using lab-grown tissues because they are much more accessible. And at the moment we don't have the regulatory certification in place to actually use this on patients, though we do know it's very safe from the previous work that's been done in the cervix, for instance. So that would be one of the important next steps in what we're doing.
Amazing. So this podcast, our podcast, is for a wider audience. So we have, young researchers, we have members of the public, patients. So what advice would you give them in terms of, having that kind of technology being available in the digital health field? So if they want to get involved, could they, contact you? What would that look like?
Well, Insigneo has a great support system for ECRs, early career researchers, so that's a great starting point to find out what's going on. In terms of advice for early career researchers working in this field, I'd just say digital health by definition is so multidisciplinary, and you cannot be expected to be an expert in everything. So for instance, on our project we've got researchers who are experts in modelling, experts in tissue engineering, experts in machine learning and AI. And they work so well together. And part of that is not being afraid to ask questions or look ignorant because you don't fully understand the real technical details of everyone else's field. So just being able to communicate well and to ask those questions. If you're not sure about something, don't be afraid of looking ignorant. And it's that collaboration that's so important in projects like this.
Sound advice.
Thank you.
Dawn Walker, thanks so much for sharing your insights with us today. It's been a real treat.
Thank you very much.
Welcome, Ellen Buckley, to the Digital Health Hubcast.
Hi.
Tell us a bit more about yourself.
So I'm a research associate in the Division of Clinical Medicine at the University of Sheffield, and my research involves using wearable sensors, inertial sensors, to measure people's mobility in the real world.
Amazing.
You just gave a talk to the Insigneo showcase, so can you summarize the main points of your talk?
So mainly I gave some results or some insights from a consortium effort that I was involved with called Mobilised. We were technically, clinically validating these mobility outcomes and then also looking at the acceptability and usability of those by patients. I gave a couple of insights about some preliminary data that isn't quite published yet, but we're really excited about, and talked about how we could take that forward to use in clinical trials and clinical practice as well.
You mentioned kind of the acceptability of these devices. So this was a device that goes on your lower back, right? What did patients think about them when they were wearing them for the week through the study?
For the most part, they liked them, or at least they were happy enough to wear them. We use two different devices in our research. One can be fixed with an adhesive dressing, and the other can go on a Velcro elastic strap. But yeah, we place it at the lower back so that hopefully people will forget that they're wearing it, and it not be bother their clothes, and they can sleep with it without it being too bulky and things like that. We asked people about their experience wearing it and sort of how long they would like to wear. They'd be happy to wear it for if they were asked to by their doctor, and I think something like 79% of people we think would be happy to wear it as part of clinical practice. And we had really good retention in the study and got really good data from everybody. So something like 92% of people we got long enough data basically to look at, which we think is really like a positive sign that people had sort of voted with their feet and hadn't taken the sensor off in disgust.
Yeah, absolutely. How did you come to putting a sensor on the lower back? How did you decide that was the best place?
So there's been lots of research for the longest time about where to place sensors, and every person you'll talk to has their favourite place to put a sensor, whether that be the wrist or the foot or the lower back or even the forehead has its benefits. But there was, in Mobilised, they did a big sort of consensus effort with all of the experts that were taking part, and so a colleague of mine then rated and weighted and ranked different features, so whether that gave us information about people's upper body and their walking gait, as well as that position and the accuracy of those features and things, so that we could come to a consensus decision about which was the best place to put the sensor for this study for the outcomes that we were interested in, which was primarily things like walking speed.
So you're looking at patients predominantly with multiple sclerosis.
Yes.
And I wonder if it's kind of quite common how this disease progresses over time in terms of how people's walking speed or gait changes, or is it really specific to individuals?
So MS is a really interesting disease because it affects everybody differently. As you say, it is quite heterogeneous as to the symptoms that people experience. One thing I didn't quite go into in my talk was the different subtypes of MS that exist. So people can have relapses where they have a sudden sort of burst of lots of symptoms because of activity in the brain. But there is this underlying disease progression that's being recognised by clinicians that patients have been telling them for years, I feel worse. But the current outcome measures that they have don't seem to pick that up. So clinically, someone might appear stable because their clinical rating scale of disease severity hasn't changed, but that's not necessarily very sensitive to change over time. And so we think that having a mobility outcome that people can use, we can collect data from the real world, lived sort of daily experience, can give that sort of arm those patients with that data and to then take to the patients, the clinicians, and say, look, I feel worse, look, the mobility outcome changed. So it's a really interesting space at the moment.
So I'm curious to hear about the different patient types that you experiment with your device. So was it a wide range of different ages, genders? How did that work?
So here in Sheffield, we recruited through our outpatient clinics, but we also had a restriction on who we could recruit. So the main criteria was that they had to have MS, obviously, and that their EDSS, the disease severity rating scale that is clinician provided and takes into account all the different ranges of symptoms, had to be within a 3 and a 6.5, which basically just means, it won't mean very much to people unless they know the scale, but it means that they have some mobility disability already and they might be using a walking aid. So we didn't recruit people at baseline who had no mobility disability, and we couldn't recruit people who couldn't walk. So that's going to impact the future sort of work that we need to do to see that translation into clinical practice is then so we can think about use of these properly.
Yeah, amazing. No, that was amazing. So going to the final question. This is a very topical area because MS is in the news quite a lot recently. So what would you say if people are interested in working with you, in working in this area? They are early career researchers. So what is the work, in the landscape of digital health in that specific area?
Yeah, it definitely seems to be something lots of people are interested in. Even just yesterday, as we're speaking, the government released the NHS plan for the next 10 years, and that included lots of wearable discussions and how that embeds with their clinical healthcare record data. And so we really do think that it could be used in that sense and contribute to those things. As an early career researcher, it would be finding what interests you and contributing that to the field. So for me, I'm particularly interested in the minute as to how we do reach with our sensors people who might not be attending clinics. So can we recruit people remotely so that they don't have to come to outpatient clinics where we know that there are only certain demographics that are more likely to attend. And so whereas the engineers come to it as a very technical engineering problem, and the clinicians are thinking, well, I want to treat my patients. So I suppose if people are interested in the field, it's finding what interests you to get involved. And it is so multidisciplinary and collaborative a field. So get involved.
Well, that's amazing. Ellen, thanks so much for speaking to us today.
Thank you very much for having me.
Welcome, Robin Purshouse. It's really great to have you on the Digital Health Hubcast.
Thanks for having me.
So tell us a little bit more about yourself.
So I'm a Professor of Decision Sciences at the University of Sheffield in the School of Electrical and Electronic Engineering, and I'm an engineer by background, but I do quite a lot of work in public health, so looking at the health of populations and also health behaviours, the sort of things that might give rise to problems with people's health later down the line.
Amazing. So you are going to give a talk at the Insigneo showcase. So could you summarize the main points of your talk?
Yeah, so the talk focuses on one particular piece of work that we've done, and this is work that we did to support the Scottish Government's population health framework that they just published in June this year. And the sort of situation they have is that there's kind of long-standing issues with health inequalities across Scotland, and this is also true of other places in the UK, like the north of England. So in Scotland, if you look at the most deprived communities, then on average people start to experience poor health at the age of only 48, which is my age now, and that's 23 years less than in the most advantaged communities in Scotland. So you've got these huge gaps in health, And the Scottish Government has a strategy for a wellbeing economy, and they're very keen on how do they close that gap. How do you sort of level up from people who are experiencing poor health at an earlier age, so that they get to live longer lives in full health.
Wow, yeah. So tell us a little bit more then about those different initiatives and kind of how you use. Is it computer modelling you're using to understand?
Yeah, it is. Yeah, so we build two types of computer model in the work that we've been doing with the Scottish Government. So on the one hand, we've got what you would call sort of population level or macro computer models, and those we represent local authorities as the sort of unit of analysis, and we build models that try to estimate how local authorities will progress over time in some of their sort of key economic indicators, so things like unemployment, economic participation, average household incomes, but also health. So life expectancy, healthy life expectancy, and prevalence of chronic disease, for example. And we do that at local authority level using data from local authorities. And we're able to do it because we've got about 10 years worth of data, but we've also got the sort of data that describes the variety across local authorities. So you can kind of build models for different types of local authority and then try and simulate them into the future and project how you think things are going to go if unemployment changes in particular ways, for example. And that's the one kind of models we build. And the other kind of models we build are what are called synthetic populations or microsimulations. And this is where, instead of representing local authorities, which is obviously a huge number of people, sort of potentially several 100,000 people, we represent individuals or households. And there we look at kind of, if you like, it's synthetic or sort of fictionalized, if you like, biography of people's lives, but with the idea that that's realistic. So that if you look at the bit of Sheffield where I live, there's somebody in our computer model who looks a bit like me, but it's not actually me, and they get to experience certain events throughout their life, and the ones that we're particularly interested in are ones related to physical health and mental health outcomes. So we kind of build models at two different levels, and depending on the policy question we're looking at, then we might choose one model or the other. And for the work that I'm going to be talking about in the Insigneo showcase, it's those higher level models, if you like, the local authority models that we used in that work for the Scottish Government.
When we're thinking about how you can kind of have those effects on people's physical activity or people's mental health, is it kind of initiatives like encouraging people to stop smoking, encouraging people to take active travel over something else? Is it these kinds of policies you mean?
So the ones that are the types of policies that we've looked at here, so they kind of fall within the well-being economy, or what some people call inclusive economies, which is the idea of having an economy that's not just about GDP and economic growth, but it's about sort of sustainable futures and the well-being of people in society. And in those contexts, really, we're looking at sort of the upstream influences on health and well-being. So the circumstances that we all live in that tend to have a downstream impact on our lives, which is why people in more deprived communities tend to suffer more health harm than people in more advantaged communities. And that, I should say, that's even for when exposed to the same amount of health behaviour risk. So it's known that, so for example, if you've got two people who drink alcohol, so a health behaviour, and they drink exactly the same amount, then the person who's more disadvantaged is more likely to suffer health harm. So there's something else going on besides health behaviours. And so the sorts of things we're looking at are more, in this case, is more like economic strategy. So how can you, where should you focus your efforts in terms of a well-being economy to maximise health and minimise health inequalities? So in that context, the sorts of things that are in the Scottish Government's new framework are ideas like income maximisation. So trying to ensure that the poorest people in our society, the ones who have the least income, through the welfare system and through sort of incentives around work, are able to maximise their incomes. So income is a big driver here. And then another big driver is a sort of economic participation, or there's a lot of concerns at the moment that governments have around economic inactivity. And economic inactivity is definitely very closely related to health. They have a two-way relationship, one affects the other. And there, so the sort of policies that they're interested in are things that are going to support people. So if people become ill, things that will support them to continue in work or to be able to return to work. So it's very much about prevention. And while some of that is about individual behaviours and health behaviours, there's a lot more to it than that. So focus on sort of much bigger factors in our society that are influencing people's health.
Yeah, wow, that makes a lot of sense. Thank you, Robin. Do you have any questions, Marjorie?
No, I'm just very curious for you to elaborate a bit more on what you see as the societal impact. So if those modelings that you are doing, they are taken into account by governments, what do you see as a positive or maybe a negative impact on the society?
Yeah, so we're the kind of geeks, so we're at the sort of policy analytics end. So the people we tend to work with directly are policy analysts or economists inside the government. And what happens inside the government is that there are sort of policy debates and policy processes, and policies get produced. And we're sort of contributing to that discussion and providing evidence for it. So in the case of the population health framework, the work that I'm talking about today is cited in the evidence paper that comes with the framework, and they discuss some of our findings. Our findings tend to focus on income and trying to increase economic participation, and it's really good to see that those are things that are actually focused on within the framework. So that's kind of the policy debate and the policy making end. So what happens next, hopefully, is that policies get implemented that are actually supporting things like income maximisation, and then you've got those kind of quite long-term causal processes. So in our modelling, we estimate that you don't really start to see any benefits in terms of health, and we focus particularly on life expectancy. So we start to see improvements in life expectancy in our projections after about 5 years, which is a bit uncomfortable if you're a politician in a 5-year sort of electoral cycle, because it's going to take quite a long time for those benefits to be realised. But that's kind of the nature of these things. These are kind of very long-term processes that take a while to occur. So I think we would start to see improvements in life expectancy depending on exactly how these policies are implemented. You could see reductions in inequality. Obviously that requires some focus on areas that are more disadvantaged to sort of bring them up. And I think you'd start to maybe see it in 5 years. And generally speaking, if you look at the evidence on life expectancies, if in good conditions, in sort of a happy, healthy society, then you can expect about 2-year improvement in life expectancy per decade. So, and our forecast said that you could probably get about 1 to 1.5 years in a similar time frame if you implemented these kinds of policies to support people.
Wow, amazing. So let's finish by, Robin, asking you if you have any advice for early career researchers interested in getting involved in your kind of area.
Yeah, sure. So I'm an engineer by background, and I do see a few people who are similar to me, sort of from physics and maths and engineering, wanting to make a contribution in population health. And I think the key sort of learning point or advice I would give is to understand that the data that exists in sort of societal data and health data is much messier and more full of gaps and errors than in the physical sciences, where you tend to be a lot more free to make measurements. Measurements are very costly if you want to measure what's going on in society. You don't tend to measure them very frequently. You might not be able to get more than one measure of the same person. You might have to, deal with the fact that it's always different people who get measured, and you've also got the fact that also society is reflexive, yeah. So it doesn't just sit there and let you observe it. It's responding, So whilst you're busy building models to support a policy debate, that policy debate is moving on, and and society is changing, as you're trying to analyse it and measure it. And so I think there's a lot to be said for kind of being quite humble in terms of what sort of mathematics and computational methods can actually provide in this sort of environment, and that computer modelling is only ever going to be one part of the story, and maybe quite a small part of the story that actually ultimately leads to policies being implemented. That's so that's something to really bear in mind when coming at it, wanting to build computer models of people's lives.
Oh, amazing. Robin, thanks so much for coming to speak to us this afternoon.
You're very welcome. It's been great.
Thank you.
Wow, what a day. Really big thanks to all of my guests, to Dr. Dawn Walker, Dr. Ellen Buckley, to Professor Robin Purshouse, and of course my lovely co-host, Dr. Marjorie da Costa Abreu. I always come away from these days feeling energised and inspired by all the amazing research that's going on, and gives me hope for the future that there are good people doing good research, really trying to make things better. Thanks so much for listening to the Digital Health Hubcast. I'll see you next time.